Welcome, viewers. Today, our guest is from the city of Pune. We dive into the world of orthopedic onco surgery, and he is a pioneer in the field. Dr. Yogesh Panchwagh. An orthopedic oncosurgeon is one who specializes in the diagnosis and treatment of tumors of the bone in our skeletal system. Let us discover the surgeon's extraordinary journey from the operating room to marathons and his trekking adventures. Join us for a dive into a life dedicated to healing, resilience, and pushing his physical limits. This is MedVentures, and I am your host, Vivek Vincent. Let's explore the incredible story of Dr. Yogesh Panchwagh together. So I welcome you, Dr. Yogesh.
Thank you very much, Vivek. Thank you for hosting me.
Yeah, it's a pleasure, sir. For all the viewers, Dr. Yogesh was one of my teachers at Pune. So I'm really honored, sir, for coming and joining us in this podcast.
The pleasure and honor is mine. Thank you.
So whatever I know about you is only as a dashing orthopedic onco surgeon. Can you just tell me something about your childhood? How was your childhood? Why you chose to become a doctor?
Well, as a kid, there were no plans to become a doctor till I crossed my, passed my 10th standard and went on to junior college. That is when I really started thinking about taking up the medical branch. My grandparents from my mom's side, they were doctors. They had this old LCPS degree, which is a very old degree at in the British era.
Okay.
And they used to practice in a very remote village in the Satara district of Maharashtra. I used to see them as a kid whenever I used to go to my Nanihal, that is my mom's house.
Okay.
And I used to see them attend to patients. I used to ride with my grandfather on his bicycle as he used to visit villages nearby for doing medical checkups for patients and all. And my uncle has been a doctor also. That time there was a combined degree, MB and BS. So it was kind of an Ayurveda allopathy combined degree at that time. And same, during Diwali time when we used to visit him, our ancestral house in our native village, we used to hop on his Java motorcycle and go around with him, during the night time, during the daytime. And I used to find it pretty cool, just to see him visit and talk to patients and treat them.
Right.
That time they used to carry these bags with them and with all the syringes and needles, and these were glass syringes, and there was no autoclave at that time.
Right.
So they used to boil the needles and then use them for injections and all. So I have grown up seeing them. But I had not thought about becoming a doctor as such. I had thought that maybe let's finish our 10th and 12th and then decide what's to be done ahead. After my 12th, at that time there were no national level entrance examinations. We got admissions to medical colleges or engineering colleges based upon our physics, chemistry, biology or physics, chemistry, mathematics totals.
Right. Oh.
And I had got admission into BJ Medical College and I said, okay.
In the first shot?
In the first shot, yes. Okay. So it was it was based on the totals of physics, chemistry and biology. So I got the admission. I was also getting admission to College of Engineering, Pune, in all the courses except one that was instrumentation engineering, which had only 3 seats at that particular time. Okay. So we were waiting for the engineering admissions to happen, but that never happened till November, December of that particular academic year. And I had already finished my first term of first MBBS. Okay. And then when the engineering admissions were about to happen, I said, okay, I think I kind of like this. Yeah. I had kept my mind open.
You're in the groove.
Yeah, I was in the groove. I had started liking the subjects. I had started liking anatomy a lot, physiology also as well. Biochemistry was not that great a subject from my point of view. But then I said, okay, I have already finished one term. My first term examination was over. And then I had no inclination to go and appear for the engineering admissions. Right. Probably if the engineering admissions would have happened earlier that year, the story might have been different. Okay. But that was as simple a reason as that I came to medicine. And since I started liking it, I said, okay, let's stick around with this. So I never went for the engineering admission.
Okay. So what triggered you to orthopedics? Was it during your MBBS?
Yes.
Some role model, someone during your MBBS?
Yes, that time, orthopedics was the in thing.
Yeah.
We had a lot of dashing seniors, as we would put it, who were our
All
kind
the
of role
good-looking
models.
studs.
No, not good looking studs, but all the the brilliant guys, the
Right.
brilliant chaps, and they were all into. They're all either taken up surgery or orthopedics.
Right.
And orthopedics was considered a step higher
Right.
than general surgery. And people knew that probably after general surgery, you would be looking at some sort of a specialization. That was an era where super specialization was not in vogue yet. But orthopedics has had a different charm. And hence, that was playing on my mind. And I said, okay, it was going to be either between surgery and orthopedics. I was more inclined towards orthopedics because a lot of my seniors, my friends, they had become my friends by that time.
Right.
And they were into orthopedics. They were also guiding us as an undergraduate.
According to I think you joined in which year your ortho career?
My orthopedics started
post-graduation?
In 1999.
99.
Yes.
Okay.
So what happened during that period was Maharashtra government made it compulsory for pre-PG students to do 1 year rural service compulsorily.
Okay.
So that certificate was necessary for us to join post-graduation. Without that certificate, you could not start your PG. So that's not something that we liked to do.
Right.
But again, as I would put it now, looking at it retrospectively, that was a great learning experience. One, you were in charge of a primary healthcare center in a rural area. You had to deal with a lot of people, a lot of health conditions from a preventive social medicine point of view.
Not only orthopedics.
Not only orthopedics. It was all preventive and social medicine on a very primary, basic healthcare level.
So which improved your confidence?
Yes, you could judge people. You knew how people are, who is going to take you for a ride, who is going to work sincerely, how to deal with leaders, how to deal with, say, someone like a reporter from press during that time, how to deal with mass casualties like a big bus accident or say an epidemic like gastroenteritis, stuff like that.
So then after 99, you joined Sancheti Institute?
Yes. Yes. So again, there is an interesting story there. The seats were very few. There were only 2 seats of orthopedics. One was in the government medical college, that is Sassoon General Hospitals, and one was under Dr. Sancheti.
Okay.
And as I just said, there were a lot of court cases happening around that time.
Right.
Had I waited for 6 months, I would have got the government seat. So again, the big question was whether I should just sit for 6 months, not doing anything or doing something else, and then take up the seat coming up next. So I happened to speak to a lot of people. The decision between waiting for a government post versus going for a private kind of an institute with maybe a limited hands-on experience, that used to be the concern at that time.
Right.
In a government institute, you are going to get to do a lot of things hands-on, but there are not going to be many people to hold your hand or to guide you or to teach you.
To guide you the right way.
Yes, in the correct way. Vis-a-vis in a private institute where everything is going to be monitored, you will be guided, your hand will be held to begin with at least. You might not get a lot of cutting hands-on by your own till you become a third-year resident. But you will be taught well. You will be exposed to a lot of different branches of orthopedics. So again, I spoke to a lot of friends, to a lot of teachers at that time, and they were right in guiding me that it doesn't make much of a difference after a few years of passing out from your post-graduation. A few years of work experience at a hospital, maybe a government kind of a setup, would take care of most of the, sort of inhibitions or, the confidence, the fear that you might have of not being able to do certain things on your own.
Right.
So a couple of years maybe at a hospital, at a government level, would take care of that kind of an experience. Yes.
Okay. So then now the general trend of an orthopedic surgeon currently is once you finish your ortho post-graduation, either you can focus on trauma.
Yes.
You can focus on joint replacement.
Yeah.
You can focus in sports medicine. You can focus in spine surgery. What made you choose onco as a department? Was it very relevant at that time?
During my residency, I hardly got to see any oncology cases, orthopedic oncology cases.
More of trauma.
More of trauma, a lot of joint replacements, a lot of cold orthopedics like corrective osteotomies, non-union treatments, a little bit of spine. Spine work was not that advanced at that particular time. Basic spine work was being done, fixations were being done, pedicular screws had just been introduced. In fact, when I started my residency just a couple of years back, the interlocking nails had been introduced. So it was that kind of an era where orthopedics itself was kind of transitioning between the old kind of implants towards the newer kind of implants with the AO principles coming into play and all. So I realized that I had hardly seen any onco cases during my residency, maybe just 3 or 4 tumor cases. And the trend at that time was to send everything to Tata Memorial Hospital in Mumbai, because our institute wasn't handling those cases. And most of things were being referred. And I realized that I have to learn a little bit about this, because this is one thing which we have not learned at all. It was a niche field. The decision was going to be a bit tricky. And that time I said, okay, I had an idea that I won't be working at Tata Memorial Hospital for more than a couple of years. I had my family back in Pune. My parents were getting a bit old, so I had to go back to them. It was not going to be possible to maintain 2 residences, one in Pune and one in Mumbai, and then keep on shuttling over the weekends, though the cities are geographically pretty closely located. So I decided, okay, someday I have to go back to Pune. And then at that time also, since Pune was having a lot of orthopedic surgeons, practicing inside the city, I said I have to have some specialty. Now the question was that whether to do both, the super specialty practice as well as a bit of routine orthopedics, trauma and all. And I said, okay, let me give myself about say 7 to 8 years time and see how this goes. If at the end of 7 to 8 years I feel that I have not been able to, generate enough amount of work, then might as well rethink and start doing everything. So the challenge was the perception of people. Perception of people that someone could do orthopedic oncology outside of government institutes. I was probably the first person in India to do practice orthopedic oncosurgery completely on a private level. So till that time, there were other senior colleagues of mine who had practiced in both private as well as government setups. But they used to do a lot of orthopedic oncosurgery work in a government hospital.
What gave you that confidence or that boost that you would do this alone, or you would be the first one? Was there a dream? Was there a vision that you would want to become something? Or
I wouldn't say it was a dream, or it was kind of I was hell-bent on doing this. I was also a bit unsure. I was a bit tentative about what's going to happen in the future, and that's when I say that I had given myself 7 to 8 years of time. Other specialties, broader or commoner specialties, would take about 3 to 4 years maybe, or at the most 5 years. I said, okay, this is a niche field. This is a completely, even the problem here is, there are a couple of problems in orthopedic oncosurgery. One is the incidence and prevalence being very low. It's not that, in our routine orthopedic OPD, we see a lot of patients with backache and knee pain, and, we can generate a lot of operative work when we see a lot of volume of these particular patients. The incidence and prevalence of orthopedic oncology patients is itself very low. So, about 3 to 4 patients per million population per year for primary bone sarcomas. Maybe benign bone tumors like giant cell tumors are more commoner. So that work was anticipated to be a bit more than the primary malignancy work. The second problem in this particular field was regarding the socioeconomics, which I actually did not anticipate well when I started my practice. So the socioeconomics of this particular branch is very peculiar. For example, when a patient comes for joint replacement, he's prepared in his mind that, okay, I have to spend such and such amount for getting this done.
He has an idea.
Yes, he has an idea, or he has an option of not going for it, not getting a joint replacement done. In oncology, when a patient has a malignancy, that's not an option of not being treated. He has to be treated. And by that time, we knew from literature and publications that amputations need not be done in all the patients, and limb salvage surgeries gives a similar outcome as far as overall survival is. Yes, as far as overall survival is concerned, and the patients could have their limb retained and saved, salvaged. So, but the economical aspect was something that was again a bit of a problem, because chemotherapy, surgery with a mega processes, for example, or some sort of a massive reconstruction followed by more chemotherapy, sometimes radiation added to it, All of this would take the cost to almost maybe 4 or 5 lakh rupees in toto, maybe more in certain cases if the patients needed more supportive care. For example, if they become neutropenic during chemotherapy, if they have to be admitted, given blood products for supportive care, the cost is going to be jacked up multiple
There
times.
is a huge battery of
Correct.
tests and
Correct. So, yes.
procedures which they need to.
That's right. So that's where the practice in a government setup and a private setup differs.
Okay.
So then I realized that this is going to be a bit tough. We continued with it. We sort of had fortunately, I was also working at Dinanath Mangeshkar Hospital in Pune, which has a very good system in place for doing charity work. So they have a charity office, they have medical social workers who will screen patients, who will talk to them, who will find out how needy they really are. And then they know various channels through which help can be generated. And I could do free cases also in deserving cases, in deserving patients. So that was another help, and that actually made it possible to start doing limb salvage surgeries and major oncology reconstructions at a reasonable rate, I would say.
Being from a family of doctors, did anyone discourage you that, see, focus more on orthopedic trauma, don't try something new?
No, my grandparents were long retired, and as I mentioned earlier, they were practicing in a very rural area. My uncle used to practice in a rural area, so they did not have the idea about this particular branch per se. Neither did they have any idea about the complications of an urban practice in a niche field. My senior colleagues, my seniors in orthopedics in the city, they told me that, okay, Yogesh, we don't think that this is going to be a viable option. We don't think orthopedic oncosurgery per se on its own, you will be able to survive. So either you have to practice general orthopedics, or maybe another specialty you can take up along with oncosurgery, or then you'll have to sort of compromise on your principles, start doing things which you don't want to do, start, say for example, start giving referral charges to people, which I again didn't want to do. So I listened to them, I heard them out, and I said, okay, let's see for about 8 years, let's see what happens. So I'm happy to say that I did not have to compromise on anything. I had a lot of patience, and that is one thing that helped me a lot. Having a lot of patience is the key. You cannot expect, especially in a niche field, that you will be having a roaring practice right from the first month, second month, third month. You have to wait it out. Fortunately, till date, I'm happy to say that I've never compromised on my ethics and principles. So that was one thing, and did not have to look at other field also at the end of 7 to 8 years time. I said, okay, I'm reasonably on the right track, so let's continue with this.
So finally you are happy and satisfied with your decision.
But that's after 17 to 18 years of practice. It's been 18 years actually.
It's been
18 years since I started my private practice. It's been 20 years in the field of orthopedic oncosurgery.
So now such a long, almost 2 decades of your practice now. Is there any very life-touching or heart-touching incident in your life which one particular case, one particular patient who has really touched you and you will never forget that patient? Is there something which you remember very vividly in your mind?
Oh, there are a lot of patients. In fact, there was this young guy. He was only 8 years old. He had an osteosarcoma in his distal femur, but his joint could be spared, and we did what we call as an intercalary resection and reconstructed using vascularized fibula and plating and all. For some reason, he had a very stormy post-operative course, and he ended up in the ICU. He ended up being on ventilatory support for quite a long time. Came for a very poor background in a village near Kolhapur, and the hospital helped him, treated him free of cost. And he fortunately survived. He became a survivor.
Great.
He's a survivor now. He's completed almost 15 to 16 years since his diagnosis, and he went on to become the bodybuilding champion in the disabled championship on the national level. So he got a silver medal. He was the runners-up. So he dreamt to become the winner, to win the gold medal, so that he could represent India on the international level. So that was one story. That was one patient that comes to my mind, and there are a lot of others. So every patient is actually a story in its own.
So when you say dealing with cancer patients is not something easy.
Yeah.
I mean, you see people from all kinds of economic strata,
Yeah.
the rich and the very poor. How much, when you look at them, how much does it take a toll on your mental self when you look at them, looking at how badly they are suffering? As an individual, as a doctor, what goes through your mind? I mean, how do you look at them?
Well, it was pretty tough to in the beginning of the practice, because I think I was trying to link whatever I have done or I could do for them to their outcomes, and it takes a little while to understand that you're not really responsible for what is happening to them.
Right.
And neither are you responsible for the overall outcome in that particular patient. So it took me a while. In the early years of practice, I used to say that this patient is my responsibility.
You are very emotionally connected.
Very emotionally connected. This patient is my responsibility. I should see that he or she is cured. He or she leads a good quality of life.
Right.
And then then it hits you. It starts hitting you. Not everything is under your control. There are certain things that are going to go wrong. The disease is going to catch up in at least 30 to 40% of the patients. They will have metastasis despite the best of the efforts that you have done or you have taken, or the treatment that you have given. They are going to end up with pulmonary metastasis. Most of them are not going to make it alive through the disease. And that's when you really need to read. I had to retrain myself, my thinking, my mind, as to dissociate a little bit from emotionally.
Be a little more harder.
Not harder.
Okay.
I'm still compassionate.
Okay.
I'm still compassionate towards them, but I had to dissociate myself from being responsible for their overall outcome.
Right.
So I said to myself that, okay, what is your job? Your job is to try and give them the best treatment that's possible. Try to see that they get to complete their entire treatment and not leave it in between incomplete. And then everything is left to their fate. That you have to accept. And I had to retrain myself for doing that. It was not easy.
Right.
It took me almost 8 to 10 years.
So would you lose your sleep at night? Would it really, when you see such patients, when you come back home, does it, like, you're in a bad mood? Does it disturb your
Yes, to a
family?
certain, to be very honest, in the beginning it does. It does affect you. It does play on your mind. It hampers your interaction with your family members. Sometimes you would tend to take out your frustration on them, on the family, on your kids maybe. It does happen. But that's exactly what we need to learn as we grow in practice.
So that comes only with experience?
Only with experience. You have to go through it. I mean, no matter how much your seniors are going to tell you, you have to just go through it to learn, to be able to not let your professional life affect your personal life. But yes, it does take a lot of a toll. So there have been some horrible complications in my cases as well, and they are always going to happen. If if a surgeon says that I don't have a complication ever in my series, then either he's lying or he's not operating. It's as simple as that. So complications are going to happen, and we need to be ready to face them. We need to be well trained to handle them properly. And first and foremost, we need to be very open and honest and have a very good communication with the patient and the family. So what used to happen initially, I used to be afraid that I might lose this patient if I give them a negative outcome or a negative kind of a picture. And I used to not focus a lot on the complications while counseling them. I used to talk to them a lot. I still talk a lot with the patients and the relatives. Talk to them on multiple occasions, explain things to them, slowly break the bad news, slowly break the complications that are expected. Initially I used to be afraid of talking about the complications. Now I am not. Now I focus more on the bad part than the good part. Now I am not worried about losing the patient. Over years, with experience, I have realized that that's not what I should be worried about.
But as a junior doctor, now if we tend to talk about complications, we may feel that anyway the patient, even if we explain,
Yes.
will go to the senior doctor for
Yes.
further treatment.
Yes.
So, what is your, so from the beginning, we need to be truthful? Do we need to be empathetic?
Absolutely. Absolutely. You have to have a very good communication level with the patient and the family. We have to be truthful. And I will tell you that you should encourage them to take another second opinion or third opinion. In fact, I would say that you should facilitate it.
Right.
So if a patient thinks that something is not being done or something more needs to be done, we should be the ones who should ask them to seek another opinion. That we do very regularly now.
Okay.
If a patient doesn't seem to be convinced with our plan of treatment, I would always refer them to my seniors in the field.
Okay.
I will ask them to take that effort to travel to meet people. I'll talk to them, I'll write a mail to them, or I'll give a letter.
Right.
I'll set up an appointment.
Okay.
Ask them to go over, have a word with them, take a separate opinion. A lot of things happen.
Right.
So I remember a patient who of a pathological fracture, who I was about to operate. I had not even incised, and while intubation, he had an myocardial infarction. He had an heart attack. And I could not do the surgery, obviously, but I had to take care of all the complications, all the social complications that came with it. Not my fault altogether, but since the patient was admitted under my care, I was the kind of responsible person. So you have to, sort of take up that particular role. So that actually takes a toll on you as well.
Yeah.
So, in these cases, you have to be open as much as possible. You have to give them an opportunity of going for a second opinion, not be afraid of, sort of into inverted commas, losing the patient or being, chastised or something like that.
So I think communication is the key.
Communication is absolutely the key.
I think nowadays many people lack, or I think I have seen a couple of people during my limited tenure into medical practice that communication is very less.
Yes, we are not trained in medical college regarding this. We are not trained on the soft skills.
Right.
We take up or we learn these soft skills only with our practice, only as the years go by. So nowadays, I think the curriculum has been changed and the soft skill exposure is being introduced.
Right.
But again, I would say that apart from the curriculum, it is your own experience that is going to build up on this particular thing.